Before we get started with today's episode, I just want to take a minute to let you know about Coastal City Ballet's upcoming performance of Swan Lake. For those of you who may not be aware, Coastal City Ballet is a repertory ballet company located right here in Vancouver. The company provides dancers with professional quality performance opportunities and training in preparation for a career in dance. They are mounting a full-length production of Swan Lake coming up on May 15th at Centennial Theatre in North Vancouver, as well as June 5th at the Surrey Arts Centre. We are fortunate to have so much incredible dance talent in Vancouver, but it's still a bit of a rarity for us to get to experience a full-length classical ballet in this city, which is why I am so excited for this upcoming production. Coastal City Ballet has generously provided a discount code for you, the listeners of the Dance Physio podcast. So you can go to coastalcityballet.com and use code CCBFriends for 15% off your tickets. And now, here's today's episode. Hello, and welcome to the Dance Physio podcast. A podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started. Hello, everyone, and welcome back to another episode of the Dance Physio podcast. I am your host, Erika Mayall. Today's episode comes to you courtesy of a request from Christy, who requested an episode on calf injuries in dance. And I've sort of touched on a few things in the past. So I have done an episode on Achilles tendinopathy. That is episode 97. So if you are more interested in that, go have a listen to that episode. I'll put it in the show notes. And I've also done an episode on posterior ankle impingement, which is something that sometimes gets confused with an Achilles issue, like the diagnosis sometimes gets missed or gets mixed up. So I have a podcast episode on that as well. That is episode 24. I will also link that in the show notes. So for today, I thought I would focus on calf strains specifically. So Christy, hopefully this is helpful to you, and hopefully this is maybe what you were angling after. But like I said, there are some other episodes, and I also realized I have not done an episode on actual Achilles ruptures in dance. And so I will probably do that sometime in the future as well. But today we are specifically going to focus on calf strains in dance because we haven't done this before. And this is a relatively common injury, I would say. When we think about calf strains, they sort of fall into two categories. So we can have calf strains that are a result of overuse injuries, or what we actually probably see more commonly are calf strains or calf injuries that are an acute injury. So they happen kind of all of a sudden. So I'm going to talk probably a little bit more about the acute side of things, but when we get into treatment and all of that, we follow the same principles for an for an overuse injury as we do for an acute injury. There's just a little bit of variation around maybe timing of the protocols and things, but I will get into that. So I am mostly talking about these sort of more acute calf strains that we see in dance. And because the calf is a muscle, when we are talking about calf strains, this is a muscle strain injury. And I have done an episode in the past that talks a little bit very generally just about muscle strain injuries and how we classify them. So that episode is titled Sprains, Strains, and Itises, I believe. And it's just about the difference in classification of when we call something a strain versus when we call it a sprain. So I will put that episode in the show notes as well if you want just more general information. But as a reminder, and specifically pertaining to muscle strains, we grade these injuries on a grade 1, grade 2, grade 3 scale. So a grade 1 injury is a minor tear of the muscle. And sometimes people get really specific about what percentage of the fibers of the muscle are torn. And unless we're doing a lot of detailed imaging and sort of diagnostics in that sense,
I don't necessarily think that it's that helpful, but we can think about this as more of a minor tear. And then in terms of how these people present, what we will see is generally there's a lot of tenderness in the muscle, but one of the classifications of a grade 1 is that they've actually maintained their strength. So the muscle can still generate strength, but it's going to be painful when they do it, most likely. It's usually painful when they stretch the muscle, and there's some amount of tenderness involved as well. So that's kind of what we'd be looking at with a grade 1 strain. And this is probably, if we're thinking more of the overuse calf strain injuries, they more often probably fall into a grade 1 category where we're maybe getting these like micro tears that are happening. And if the load that we're putting on the muscle is exceeding the muscle's ability to recover from those micro tears, they can progress to more of this sort of minor tear that we would then classify as a grade 1 strain. So that is often what we're seeing with the overuse type injuries. With the more acute injuries with a calf strain, then we might be more likely to see a grade 2 or a grade 3. We can see a grade 1 as well, but we might also see grade 2s and grade 3s, whereas I don't see as many grade 2 and grade 3 injuries happening from overuse as often. So a grade 2 injury is a partial tear. So again, we're using like very sort of ambiguous language, like a minor tear, a partial tear. So if we were starting to think about percentages, a partial tear or a grade 2, we sometimes say up to 50% of the fibers of the muscle are torn. So between 25 and 50, minor tear would be under 25%. Again, we have no way of actually quantifying this unless we're doing really detailed diagnostics. But clinical presentation wise, what do we see? Generally, grade 2s are going to be a lot more painful. In fact, they are often very painful when it comes to calf strain injuries. There's often, I'm not going to say always, but there is often significant swelling associated with a grade 2 muscle tear. And there's definitely going to be a loss of strength in these presentations. So in that grade 1, we can still generate strength and power generally. It's just potentially uncomfortable or sore to do so. But in a grade 2, there is going to be an actual objective loss of strength. We will sometimes see bruising associated with a grade 2 tear as well. Not always, but very often we're going to see some bruising that goes along with that swelling. And then in a grade 3 injury, we are going to have a complete rupture of that muscle. Again, with these ones, generally like quite severe pain. And a significant loss of function. And so that's that loss of strength. But also we see way more functional impact in the sense that people can't like walk. They can't necessarily like push off, like to have a normal gait pattern. A lot of times people actually can't even get their heel to the floor when they're standing, like their heel's a little bit elevated. So we see a much more significant impact on function with these complete ruptures. Interestingly, and I'm going to get into this a little bit in terms of what muscles we commonly see injured and all of that, but because we have multiple muscles in our calf complex, so we have our gastrocs muscle, but it has 2 muscle bellies or 2 heads, and then we have our soleus and we have our plantaris. We have a bunch of different muscles back there. We can have a complete rupture of one of these muscles and still be able to do certain functional things. And this sometimes surprises people because they think, oh, I couldn't have possibly had a grade 3 injury or ruptured this because I can still do X, Y, Z, depending on what those activities are. But when we look at isolating that muscle, so if we're testing it and trying to really isolate a specific muscle, then we see this profound loss of function. So I'll get into that a little bit more in a second. In terms of calf strain injuries in dance in particular, if we look at the prevalence or the incidence of these injuries, there's actually not a huge amount of literature that is specifically looked at this. When we sort of are looking for data on it, often what we're seeing is where they've done injury surveillance across a company or across a dance program over the course of a season, and they're tracking what injuries are showing up. And so then they're saying, okay, we had X number of calf strain injuries, but there's very little data that specifically is looking at calf strains, at least that I was able to find. So there has been a little bit. And there was one study that was done on professional ballet dancers, and they were looking at the incidence rate between male and female dancers, and they had 0.39 injuries in 1,000 hours of exposure. Sorry, I was just looking at my numbers to make sure I was getting the numbers right. So in the male dancers, it was 0.39 per 1,000 hours of exposure. And in the female dancers in that same company, it was 0.17 per 1,000 hours of exposure. So those numbers aren't necessarily super, super high, in the sense that we do see some injuries that have much higher rates, or when we look at overall injury rates in dance, those numbers are higher than that. But if we think about dancers in a professional company setting, 1,000 hours of exposure is not actually a huge amount of hours. Dancers get to that reasonably quickly. And so if we're thinking that, almost 0.4 dancers are going to have a calf strain injury over that 1,000 hours. Like, those numbers, they're not super low, I guess is what I'm trying to say as well. So certainly not the highest injury rate that we see, but not insignificant. Another study looked at a company and following them. Again, this was one of the ones where they were just doing injury surveillance over a whole season. And they had 15 calf strain injuries over the course of a season. And I should go back and look, but I don't remember how many dancers they had in this company. But they had 15. And this was actually one of their highest injury rates when you looked at what all of the other injuries that they had within the company. The Royal Ballet has shared a little bit of data. This isn't published, but they have shared a bit of data in terms of looking at their own injury surveillance. They went back and looked at 5 years of data. These numbers are a little bit old now, but they looked at the previous 5 years to figure out, okay, what's the burden of injury of calf strains on our dancers? And they had approximately 9 calf strain injuries per season over a 5-year period. So they had 46 in total over a 5-year period, which worked out to be approximately 9 per season. And interestingly enough, about 50% of those injuries that they had were time loss injuries. So when we think about injury rates and like injury risk reduction and things like that, we know that we have high injury rates in dance, but we also have high rates of what are considered minor injuries or often do not result in time loss. But these injuries generally do, or I shouldn't say generally do, 50% of these did result in time loss, which is pretty significant, and especially in a company like Royal Ballet that is, performing really consistently over the course of a season. So it's something to keep in mind when we're thinking about these, that these are often going to be injuries that do result in time loss compared to potentially some other injuries we see that may not. In this same data that Royal Ballet shared, their mean return time after these in terms of time loss was 20 days. And that's very consistent with injury healing timelines of muscle strain injuries when we look at other data for other muscle strain injuries. So again, we're not necessarily looking at injuries like when we think about stress fractures and stuff where our time loss, the actual number of days is really, really high, but at least about 50% of these are time loss injuries. And then they also found that the average age of their dancers who were sustaining calf strain injuries was about 32 years old, which in terms of dance company populations is on the older end of dancers. And I would say this is pretty consistent with what I see in the clinic, in that I see a lot more calf strain injuries occurring in my adult dance population than I do in my adolescent dance population. And there may be a variety of factors that are contributing to that, but it was interesting to me that Royal Ballet had similar number or a similar finding in that it was happening a little bit more in slightly older dancers. They also found the same as the previous study that I mentioned that had a higher rate of these injuries in male versus female dancers. That was consistent as well. And there's potentially a reason for that we'll get into now, because one of the primary causes, or one of the things that causes these types of injuries, is jumping. And both the taking off for jumping is sometimes when the injury occurs, and the landing from jumping. And some studies have tried to look at separating that data of like trying to track if it was more a takeoff versus a landing, but all of it is jumping. And so if we think about, especially those studies that I'm referencing were all done in classical ballet companies, if we think about the traditional gendered roles of a male versus female in a classical ballet company, the men are often doing the larger jumps, the more sort of dynamic jumps. And so it is maybe unsurprising that we see a slightly higher rate of calf strain injuries in male versus female dancers. That being said, the chronic overuse type injuries, we potentially would see a higher rate in female dancers, because those ones can be linked more to repetitive, like releve or point work. And so again, we kind of have to separate it out a tiny bit on these like more acute injuries versus the more chronic or overuse injuries, because the mechanisms are generally or are likely going to be slightly different. In terms of where the injury is actually occurring, generally we see it more commonly in the gastroc muscle than the soleus muscle. Those are the two biggest muscles in the calf complex. Very rarely does it happen in the plantaris muscle, although we may just be like not diagnosing that super correctly because we have other muscles. If it was an isolated plantaris injury, we have soleus, we have gastrocs, we have all our other foot extrinsic muscles that can probably compensate functionally. So it's quite possible that there are more plantaris injuries happening than maybe we are actually diagnosing, because functionally they might be slightly less impactful. But between gastrocs and soleus, we see more injuries in gastrocs than in soleus. And from my clinical experience, and I didn't see anything that actually differentiated this in the literature, but from my clinical experience, I see way more in the medial belly of the gastrocs than in the lateral belly. And I think that is consistent in athletic literature. But like I said, in the dance literature, none of the studies that I looked at actually differentiated. They differentiated soleus versus gastrocs, but not medial versus lateral gastroc. And like I said, we'll talk a little bit more about the difference in those two muscle groups when we talk kind of about treatment or return to dance protocols, because functionally, we actually might be able to sometimes do more than we think we can if we can isolate one muscle versus the other muscle. So knowing which muscle is injured is actually super helpful in designing a rehab plan. In terms of presentation, I did talk about this like very slightly when we were talking about the grades of the injuries, but oftentimes, so with these acute injuries, it's usually like a sudden sharp pain. People often describe this as feeling like somebody like kicked them, or a lot of people will sort of turn around and be like, what just happened? Because they feel it happen, but it's so sudden and sort of sharp that they think that maybe, something hit them, somebody kicked them, something like that, and then realize that it was actually the muscle sort of going in that instance. So generally, it's going to be a sudden sharp pain. If it is these more chronic overuse ones, it's potentially going to be more of a dull, achy pain as opposed to the sharp, sudden pain. But what I will say that I have seen as well is people who maybe have had sort of dull, or often it's like describing feelings of like tightness or a dull, achy pain that's kind of low grade, and people sort of try and ignore it or pretend it's not there. And then one day they go to do something and get sort of a sudden, sharper pain on top of that. And that's probably the muscle was already overloaded. It was showing signs of this chronic overuse injury. And then there was the proverbial straw that broke the camel's back that then sort of maybe was an acute on chronic type injury. A lot of people are going to present with stiffness and tightness after these injuries. And sometimes, like I just said, in the case of more chronic ones, that actually might present even before the sort of more acute episode. Usually there's going to be pain with walking, rising onto demi-point or point, or they're going to be unable to do that. Like I said before, sometimes getting heel onto the ground, heel striking, certainly jumping is going to be impacted, or they're not going to be able to do it. We often have swelling associated with these injuries. Sometimes in the calf, it's actually hard to see the swelling in the calf itself, and people will only realize that there's swelling because it starts to pool into the ankle or the foot a little bit, and they'll see their toes get a bit swollen, or they'll even just notice when they're wearing socks that like on the one side, the sock is leaving like an indentation around the ankle or wherever the sock comes up to. So sometimes it is harder to see the swelling in the muscle belly itself just because it is a little bit of a more meaty muscle in that sense. Oftentimes bruising, sometimes in those grade 2 injuries, but certainly in grade 3 injuries, we often will see quite significant bruising. It can be really dramatic sometimes. People sometimes get a bit panicked about how much bruising there is, and sort of the colors it turns, but the bruising is quite common anytime we have that amount of tearing happening in the muscle fibers. It's not uncommon, though, for the bruising to take a few days to get to the surface of the skin. And so I've had people who come in for physio, a few days post-injury, and there's no signs of bruising. And I'll sort of always warn them that, like, the bruising might still come. And then I'll have people who come back for a follow-up appointment, and they're like, oh my goodness, you were right. It turned so purple afterwards because it takes a few days. So some people are like, oh, it can't be that bad. It didn't bruise. But if it's only like day 1 or 2 after an injury, or even 3 days after an injury, sometimes it's just not made its way to the surface quite yet. So bruising is common. And then depending on the grade of the injury, and again, which muscle it is, but especially in a gastrocs injury and especially a grade 3 gastrocs injury, there is usually a kind of visual or palpable deformity in the muscle. So you can run your hand over it and actually feel where there's a little bit of like a gap or a hole in the muscle. And again, that's like when we have this kind of like complete rupture of one belly of the gastrocs more commonly. The soleus is generally too deep to be able to feel like a deformity happening in it, at least in my experience. But certainly in the gastrocs, you can sometimes really visually see it or certainly feel it. So that's a little bit on how these present. In terms of treatment, what do we want to do about these? How do we manage these injuries? In the acute phase, we follow the peace and love protocol. So our peace is that protection, it is elevation, it is avoiding anti-inflammatories, all of those things that come in our peace and love protocol. One thing I will say from a protection standpoint, so sometimes people need crutches with these injuries. It's not uncommon for the first few days because, like I said, oftentimes they can't get their heel down on the ground. So they actually need like a little bit of gait support, whether it's crutches or a cane or something like that. But we will often use compression in these injuries as well because, like I said, we tend to get a lot of swelling that happens and it can pool into the calf and the foot. And so a compression sleeve for the calf can be very, very helpful in the acute phase of these when we're following that peace and love protocol. So yeah, from that the protection side of things, we may need to consider crutches, and we almost always want to consider some sort of compression. In terms of early rehab, so when we can start to, so this is after the first sort of 48 to 72 hours, we want to start to introduce a little bit of isometric muscle activation and potentially some dynamic mobility. We do not want to be stretching these injuries, and certainly not at these beginning phases. And this is one thing that I see dancers doing quite commonly is they say, oh, I think I pulled my calf muscle. I felt this happen in class. I was landing from a jump and I felt this, or whatever it was. And they're like, I've been trying to stretch it out for days and it's just not getting any better. And if we think about what's happening when we have a muscle strain injury, is we have tearing of those muscle fibers. And for that muscle to heal, those muscle fibers need to be able to sort of knit themselves back together. They need to be able to repair that damage that has happened. And if we are constantly stretching that muscle or trying to stretch that muscle, we're probably pulling those fibers further apart from each other and not allowing them to heal. So with these types of injuries, we actually really want to avoid a lot of stretching in the early phases, but we often get a lot of tightness and restriction, and that can be quite uncomfortable. So we may consider a little bit of really gentle dynamic mobility, but again, no passive stretching. We don't want to be holding stretches for these injuries in the early phases of rehab. As far as the isometric exercises go, that's where we're contracting the muscle, but the muscle's actually not shortening or lengthening during that contraction. So it's just like if we think about how we can tense our muscles up but not move our joints, it's kind of the same idea as that. But the interesting thing about this is, again, if we know the anatomy of whether it's gastrocs versus soleus, what we often can do is start to work the opposite muscle group. And this is maybe more so true when we have a gastrocs muscle injury. The gastrocs works when our knee is straight. So it's the primary muscle that plantar flexes or points our foot when our knee is straight, or helps us to go up on a rise if our knee is straight. And if that's the muscle that's injured, most people can't do that movement at all, or it's going to be quite painful. But if we bend the knees, so we've now taken the gastrocs out of it a little bit, it's not completely out of it, but it's no longer the primary muscle. The soleus muscle becomes the primary muscle that does that plantar flexion movement when our knees are bent. And oftentimes we actually can work that movement without having any pain or discomfort. And so this is sometimes people are a bit surprised where they're like, oh, hey, I can actually do this. And some people figure this out naturally. They actually start to walk with bent knees so that they don't have to overly activate that gastrocs muscle. So sometimes what we're doing rehab-wise, certain exercises might look harder than what we would expect them to be, but it's because we can isolate certain muscle groups to be performing certain actions. So early rehab, our primary goals are just that isometric muscle activation and potentially some gentle dynamic mobility, but no stretching. And then we get into the phase where we want to think about progressively loading. And so this is where we start to really want to build up strength of the injured muscle. So again, whichever one happens to be injured. So we're going to start to introduce things like calf raises. We're going to start to introduce some eccentric strengthening. So maybe some heel lowers over the edge of a step, or things like that. And with our calf raises, this is all going to be very progressive in terms of the loading. So we're going to start generally on 2 feet, and we might not be getting to full height. And then often we're going to be progressing to rising up on 2 feet, and then just trying to transfer the weight over onto the injured side and maintain the height of that releve. And then you can put the second foot back down and come back down. Then we can progress to rising up on 2 feet, transferring onto 1 foot and lowering on 1 foot. And then at some point progressing to being able to rise and lower on a single leg. So again, when we talk about calf strengthening, there's a progression of loading that is happening as well. Then we want to start to go into our more dance-specific or functional tasks. And so these are going to look like kind of releve or rise progression protocols. And if it is a dancer who's dancing on point, there's going to be point progression protocols as well. And then the really important one is starting to introduce jump protocols, because if you remember, jumping is one of the primary ways, or is the most common way, that these injuries actually occur. So we really want to look at mechanics of jumping, strength of jumping, endurance of jumping, all of that. But more often than not, we need to start jumping very slowly and gradually. I will often start this in a non-weight bearing position. So I'm lucky enough to have a reformer in our clinic, and we have a jump board for it. And so we'll often start with maybe not even jumping, but just jump preps on the reformer. And then we'll start with really little baby jumps where we're taking off on 2 feet and landing on 2 feet. And then we progress to slightly bigger jumps, or we can progress to taking off on 2 feet and landing on 1 foot, then progress to taking off on 1 foot, landing on 1 foot, those same types of progressions with jumping. And once we are tolerating that and are comfortable with that in a non-weight bearing position, then we're going to come up to a standing position and go through those same similar progressions in a very controlled, structured way. So we're almost thinking of these as more plyometric or gym type functional jumping. And again, same thing, 2 feet, 2-to-1, 1-to-1, and then start to introduce traveling jumps taking off on 2 feet, landing on 1 foot, traveling jumps taking off on 1 foot, landing on the opposite foot, all of those types of progressions before we then start to introduce more intricate and technical dance-specific jumps. So those jumping protocols, or these jumping protocols that we do with these injuries, can actually be quite long, or they are quite comprehensive, because there's so many elements of them that we need to cover before we sort of clear somebody to be able to go back to being able to jump in class. And we often are looking at having a minimum level of calf muscle strength and endurance with a single leg rise before we're even considering adding return to jumping protocols. So that is why these injuries often are associated with time loss, because it takes time to go through all of these protocols. And the time is going to be different depending on whether it's a grade 1 or whether it's a grade 3 injury. So I'm purposely not giving you really like specific time frames right now, but the protocols of how we return these people back to dance are the same. The timeline's just going to be more accelerated in a grade 1 injury, and it's going to be more prolonged in a grade 3 injury. And also a little bit different probably if it's a soleus versus a gastroc muscle injury as well. So then once we have done all of those sort of dance-specific or functional progressions, then we're going to have the dancer be ready to return to classes and rehearsals and eventually performances. In terms of prevention, because I just want to touch on this like really briefly, again, this is not an area where we have a lot of research, but an area where we're starting to maybe realize the importance of ankle plantar flexor strength and capacity. So these muscle groups, our calf muscle groups and those ankle stabilizers, they are so critical to a lot of what we do in dance. So not just jumping, but also the amount of time we spend on a releve or on point, or, you know, even just being able to dynamically stabilize when we're balancing on one foot. So they are actually expected to do a lot when we are dancing. And so when we think about prevention, we really want to think about preventative maintenance programs that work on this calf muscle sort of strength and capacity. And some of you might be familiar with some of the like single leg rise or heel raise protocols that some of the professional companies have implemented, because they found that it has so profoundly affected their injury rates in their company. But what I want to say just about calf strength in general, or like the way we need to think about it, probably for prevention of these particularly muscle strain injuries, is we want to think about strength and capacity. But when we think about that, we need to think about all the different types of strength or the different breakdowns of what we're looking at. So we want to think about maximum strength, and that's going to require loading these dancers. We're not going to achieve max strength with only body weight rises. We want to think about the power that the muscles are able to generate. And again, we train power slightly differently than we're going to train max strength. And power is also, like, I'm not going to get too much into it right now, and you can go listen to the episode on the Achilles tendinopathy. But if we think about our calf and what it connects into our Achilles, and our Achilles is the tendon that is sort of designed to transmit and generate the force and also be like load bearing or load absorbing in through there. So when we think about training power, we need to think about the entire muscle tendon complex. And so we might be looking at some of that kind of like plyometric or tendon loading or springiness type training as well. We need to think about our strength endurance. And so this is maybe where some of the calf raise protocols are coming into, because they're looking at those body weight rises, but doing high volumes of them. So doing 25 or 35 repetitions on a single leg. So that's really looking at the strength endurance, which is different than maximum strength of a muscle. We also need to think a little bit about our metabolic endurance. So what energy systems are we expecting these muscles to be able to tap into? So that might be different if we have a dancer who is doing a lot of jumping, or just like the different like repertoire that we're doing, like a jumping thing versus something that's more like sustained holds on demi point or on point. So we need to think about those metabolic systems as well, and the endurance within the metabolic systems. And then finally, we also need to consider or think about the technical strength, if that makes sense. So we can have just like straight up muscle power, muscle endurance, muscle, like max muscle strength in a muscle in a sort of quote unquote gym setting, or if we isolate that muscle and think about how we're loading it. But then we have to think about what the technical demands of dance are. So can that muscle then sustain those forces in a turned out position? Can it sustain those forces when you're doing something that's like, I don't know, sustained floor work, let's say, but where you're balancing on demi-point, or, you know, dance is so unique and so intricate in terms of the movement patterns and the positions we get the body into that we need to make sure that we have strength and capacity within those technical requirements as well. And sometimes that will look the same as some of the more functional training stuff that we're doing. And sometimes it's going to look really, really different. And a lot of times that depends on what the choreography is or what the demands are for that particular style of dance. But all of that to say that those are the things we want to think about when we're thinking about prevention. So I know so many people have really taken on board some of those like heel raise protocols and are getting their dancers to do a lot of single leg rises, which is awesome. And that is part of it. And we definitely see a decrease in injuries when people are doing those. But that is only one part of thinking about the capacity of the muscle. And so if we really truly want to think about, okay, prevention from a, more complete lens, we need to think about some of those other aspects of it as well. And sometimes that max strength, or we actually need to load the muscle like heavy, that's often missing in dancers' programs because they might only be training body weight type things. So I just wanted to throw that in because I think it's important for us to not just talk about how we treat certain types of injuries or what we do if certain types of injuries occur, but also think about what can we do preventatively, and especially knowing that these calf strain injuries tend to happen more commonly in male dancers and in potentially an older age group of dancers and with jumping type activities. If you're a dancer who falls into any of those categories, you really probably want to think about the prevention side of things. So I think that is all I have to say today about calf strain injuries. Huge thank you to Christy for sending in that request. Hopefully that is at least helps answer some of the questions you had or gives you some information that you were looking for. If anyone else has any suggestions for podcast topics or things you would like to hear me talk about on the podcast, please feel free, reach out. I add them to my list. I can't promise I'll get to them immediately, but they do stay on my list. And anytime I'm looking for podcast topics for the future, I will go back and look at that. I also do Q&A type podcast episodes every once in a while. I'm going to have one coming up in the next little bit. So if you just have a quick question that you want answered, send that to me as well. And I will always throw that into like a Q&A style episode. It's anonymous in the Q&A style, so I will not put your name in for those episodes, and you can always tell me not to put your name in. But if you're sending me a request for a topic, I will try and shout you out if I remember to write down who sent it to me. So once again, thank you, Christy. And if anyone has any questions, please feel free to reach out. Otherwise, thank you so much for listening, and I hope you have a great rest of your day.